Welcome to the deep dive.
Glad to be diving in.
Today we're tackling something, well, it's complex, it's scientific.
And maybe a bit surprising for some folks.
Definitely. We want to break it down into knowledge you can really use.
Yeah, make it practical.
We're focusing on this material in your body, the stuff that lets you bend your knees, twist your shoulders, all that smooth motion.
Mm-hmm. The cushion.
But we tend to ignore it, right? Until, well, something goes wrong. It snaps or tears or just grinds away.
And then you really know it's there.
Mm.
Or rather, when it's not working right.
Exactly. We are talking about cartilage. It really is the unsung hero of motion.
It truly is. It's the quiet engine.
Right.
So whether you're lifting because you're dealing with joint pain yourself, maybe you're an athlete with a recent injury.
Or maybe you're a professional, a student, physio, chiro, even a surgeon.
Right. Anyone looking to get a deeper understanding of this, well, this unique connective tissue, this deep dive is definitely for you.
Our mission today is to really uncover the biology of cartilage.
Mm-hmm.
Why is it so brilliant at its job, resisting these huge loads, multiple times your body weight sometimes?
Yeah, the resilience is amazing.
But then, the flip side, why does it struggle so much to heal itself when it gets damaged?
That's the core paradox, isn't it?
It is, and we've got sources covering the whole spectrum, from the tiny microscopic cells
Chondrocytes.
or up to the latest surgical techniques trying to fix it.
We're trying to connect those dots today, link that microscopic structure to what patients actually experience and what doctors try to achieve in the clinic.
And it comes back to that contradiction you mentioned, built for incredible resilience, low friction, flexibility, but its fundamental biology, its internal setup, almost guarantees a really tough recovery if it gets injured.
Precisely. That's the heart of the challenge.
Okay, let's dive straight into that contradiction, Len, because like you said, that's where all the clinical problems really start. We're calling this the paradox of cartilage, the avascular aneural challenge.
And if you want to understand why fixing cartilage is so different from, say, a muscle tear or even a broken bone, you absolutely have to start with its basic building blocks.
The cells and the stuff around them.
Exactly. The main cell is the chondrocyte. Sort of specialized, and its whole job really is to build and maintain the material around it.
The matrix.
The extracellular matrix, or ECM, yeah. And these chondrocytes, they're kind of stuck. They live in these tiny little caves or spaces called lacunae within the matrix they create.
Okay, and it's that matrix, the ECM, that makes cartilage so different from bone, right? Bone is hard because of calcium.
Exactly. No calcium in cartilage.
Yeah.
The matrix is this complex, very hydrated gel. Think of it like a very dense, sophisticated sponge.
Made of what?
It's got a fiber scaffold, mostly a specific type called type 2 collagen. But the really unique part is the huge amount of molecules designed to trap water.
Ah, the hydration part.
Yes. These are called proteoglycans, PGRs for short, and their own building blocks, glycosaminoglycans or JAGs. Things like chondroitin sulfate, keratin sulfate.
Yeah.
These give it that elasticity, that bounce-back quality.
So it can squish down and then spring back up.
Precisely. That's crucial for absorbing shock. But, and this is the big but, this structure, while mechanically brilliant, comes with these massive biological downsides. We call them the 3 A's.
The limitations.
Right. And the first one, the most critical one for anyone dealing with cartilage injury to grasp, is that it's avascular.
Meaning no blood vessels?
Zero direct blood supply. No capillaries weaving through it like in muscle or skin.
Yeah.
Think about when you cut your finger, blood rushes in, brings oxygen, nutrients, the repair crew.
Cartilage doesn't get that 911 call.
Nope, no delivery service. So it has to get everything it needs and get rid of waste through a much slower process.
How does it survive then?
It relies entirely on passive diffusion. Nutrients have to slowly seep in from surrounding tissues, either from the synovial fluid that lubricates the joint.
But the joint oil, basically.
Yeah, or from the bone underneath it, the subchondral bone. It's a very slow, inefficient delivery system.
Which actually makes movement important, doesn't it? That loading and unloading.
It's vital. That cyclic loading, like walking or running, acts like a pump. It squeezes the old fluid and waste out, and then when the pressure releases, it sucks new fluid and nutrients in. Without that mechanical pumping, the cartilage actually starves.
Okay, slow diffusion.
Yeah.
And that links directly to how slowly everything turns over inside the cartilage. The numbers you shared from the sources are just mind-blowing.
They really put it in perspective, don't they? When we say slow, we're not talking weeks or months. We're talking decades or longer.
Go on.
The proteoglycans, those vital water-binding molecules, Their half-life, the time it takes for half of them to be replaced, can be up to 25 years.
25 years.
And that's a faster component. The collagen framework, the structural beams,
Yeah.
the estimated half-life is anywhere from several decades up to potentially 400 years.
400. Okay, let that sink in. Your ligaments tear, your body sends in the troops, rebuilds in weeks or months. But damage the collagen in your knee cartilage. You're asking a structure that naturally replaces itself maybe once every few centuries to patch things up quickly.
It just can't do it. The intrinsic repair capacity is virtually non-existent for significant damage.
Which explains why natural hearing is so limited and why surgery often involves replacing or stimulating, not just waiting for the body to fix it.
Exactly. The body doesn't have the tools or the speed needed for that kind of repair job. It's trying to fix a skyscraper with a teaspoon.
Okay, so that's avascular. Huge problem. What's the second A? This one confuses people who are in a lot of pain.
Aneral,
No nerves.
meaning the cartilage itself can't feel pain.
Correct. It's completely silent in terms of nerve signals. So if you have osteoarthritis or a torn meniscus and you're feeling that deep ache or sharp pain,
It's not the cartilage itself screaming.
Right.
No. The pain comes from the surrounding structures getting irritated or inflamed. It could be the joint lining, the synovium, or importantly, the underlying bone. The subchondral bone is loaded with nerve endings.
or just the mechanics being off because the cushion is gone.
That too. Instability, inflammation in the joint capsule. All that sends pain signals. But the cartilage damage itself, silent.
Which means, unfortunately, by the time you feel significant pain, the damage might already be quite advanced.
Often, yes. The warning system is delayed. And the third, A.
Lymphatic.
Right. No lymphatic vessels either. These are part of the body's drainage and immune surveillance system.
So waste removal is even harder.
It complicates things, yeah. It contributes to a sluggish, difficult, inflammatory environment when there's damage. Inflammatory cells can get in, but clearing out debris and resolving inflammation is slow and inefficient without proper lymphatic drainage. It just adds another layer of difficulty to any potential repair.
And one final biological hurdle,
Yeah.
how it grows in the first place. It doesn't keep dividing much after we're young, does it?
No, not really. It forms initially through a process called chondrogenesis, where stem cells turn into cartilage-building cells, chondroblasts.
But once that initial cartilage is laid down,
Growth happens mostly by the existing chondrocytes just maturing and producing more matrix. There's very little cell division, very little mitosis in mature cartilage.
so those chondrocytes trapped in their little caves.
They can't just divide rapidly, crawl over to a damaged area, and fill in the gap like skin cells would.
They're stuck, and they don't multiply easily.
Exactly. This lack of proliferation is another major biological roadblock to natural repair. It's why trying to truly regenerate cartilage is such a huge challenge in orthopedics.
Okay, so we know it's biologically challenged when it comes to repair. Let's look at how it actually does its job so well when it's healthy. Section 2, structure and function, the mechanical genius of 3 types.
Right. And understanding the specific type of cartilage is crucial because function, and therefore failure mode, really depends on its makeup and where it is in the body.
There are 3 main types.
We usually focus on 3, hyaline, elastic, and fibrocartilage. But for joints, and particularly for problems like arthritis, hyaline cartilage is the main player.
That's the smooth, slippery stuff on the ends of bones in our joints.
Exactly. It's the most common type. Looks sort of pale, blue-white, very smooth. Its composition is almost entirely that type 2 collagen and those water-loving proteoglycans we talked about.
And its job description is pretty clear.
Absolutely. Provide a super low-friction surface for movement, cushion the impact, and resist compression. Simple goals, but doing it under potentially massive loads for millions of cycles requires some serious engineering.
Especially since it's so thin, right? Only a few millimeters thick.
Usually just 2 to 4 millimeters, yeah. And to manage the stress within that thin layer, it has this incredible, highly organized structure. We call it the zonal architecture. It's not just a uniform block. It's layered.
Like a specialized cake.
Yeah, a very functional cake. Let's slice through it, starting right at the top, the surface facing the inside of the joint. That's the superficial zone. It's maybe 10–20% of the total thickness. Here, the chondrocytes are flattened out, and importantly, the collagen fibers are packed really tightly and run parallel to the surface.
Like the grain of wood running along a plank.
Good analogy. This parallel arrangement makes it incredibly strong against shear stress, the rubbing, sliding, twisting forces you get when you pivot or cut. It's like a tough, smooth skin.
Got it. What's underneath that skin?
Below that is the middle zone, or transitional zone. This is the thickest layer, maybe 40–60%. Here, the collagen fibers are less organized, running more obliquely or even randomly.
Why the change?
This zone acts as the first line of defense against direct compression. The less rigid organization helps absorb and distribute the initial impact force coming down from the surface. The chondrocytes here are more rounded, too.
Okay, so skin, then a bit of a shock absorber. What's at the bottom?
The foundation. That's the deep zone, about 30% of the thickness. This layer is built purely for resisting compression.
How's it different?
Structurally, it's very distinct. The chondrocytes line up in columns, like pillars. And the collagen fibers here are the largest and thickest, and crucially, they are arranged perpendicular to the bone underneath.
Ah, pointing straight down to handle the load.
Exactly, like columns supporting a roof. This zone also has the highest concentration of those proteoglycans, meaning it holds the most water, giving the greatest resistance to being squeezed.
And this whole structure needs to be anchored somehow, right?
Absolutely. The final layer is the calcified zone. This is where the deep zone's perpendicular collagen fibers literally embed themselves into the underlying subchondral bone. There's a distinct boundary line here called the tide mark.
The transition point.
Yeah, it separates the flexible cartilage from the rigid bone. This whole graded structure, from the parallel fibers at the top to the perpendicular anchors at the bottom, is essential. It allows the stress to be transferred smoothly from the soft, watery cartilage to the hard bone without a sudden weak point at the interface.
That's incredible engineering in just a few millimeters.
It really is.
Okay, that's hyaline, the star player in joints. What about the other two types? Elastic cartilage.
Elastic is much simpler. It's yellowish, much more flexible. You find it where you need structure, but also lots of bendiness. Think your earlobes, the tip of your nose, the epiglottis in your throat.
Yeah.
It's got elastic fibers mixed in with the collagen. Less about load, more about flexibility.
Makes sense. And the third type, fibrocartilage. You said this is different.
Yeah, fibrocartilage is the tough guy. It's packed with dense bundles of type I collagen, the same type found in tendons and ligaments, making it incredibly resistant to tension and tearing, as well as compression. It has much less proteoglycan than hyaline.
Where do we find this tough stuff?
Key locations: the menisci in the knee, those C-shaped shock absorbers. Also, the intervertebral discs in your spine, specifically the tough outer ring called the annulus fibrosus, and it forms the transition zone where tendons and ligaments attach to bone.
So when an athlete tears their meniscus,
They've torn fibrocartilage, not the smooth hyaline cartilage on the bone ends, usually. A key distinction. Oh, and one other thing about fibrocartilage, unlike hyaline and elastic, it doesn't have that outer protective sheath called a perichondrium.
okay, got it. Now, let's really get into the mechanics. How does this stuff, especially the hyaline cartilage, which is mostly water, handle the pounding of running and jumping? You mentioned the biphasic medium concept.
Right. This is fundamental to understanding how articular cartilage works. It behaves like a material with two phases interacting. A solid phase, which is the collagen and proteoglycan matrix.
The sponge structure.
Exactly. And a fluid phase, which is mostly water plus ions, making up 65–80% of the tissue's weight.
So what happens when you step down hard?
When that load hits, the very first thing that happens, almost instantly, is the pressure inside the fluid phase. The water skyrockets.
The water takes the hit first.
Yes. This interstitial fluid pressure actually carries the vast majority, maybe 90% or more, of the instantaneous load. The water can't escape immediately because the matrix is so dense.
So the water pushes back.
It pushes back, supporting the load. As the load is sustained, the water does start to slowly seep out of the compressed area. As it flows through the tight matrix, it creates frictional drag against the solid collagen proteoglycan network.
Ah, like water flowing through a dense filter.
Exactly. And it's this combination, the initial fluid pressurization and the ongoing frictional drag as the fluid flows, that allows the cartilage to resist compression without the solid matrix just collapsing.
That's ingenious. And this relates to its viscoelasticity, right? It doesn't just behave like a simple spring.
Correct. Viscoelasticity means its response depends on time and the rate of loading. Two key behaviors illustrate this: creep and stress relaxation.
Explain those.
Okay, creep is what happens if you apply a constant load, like standing still. The cartilage will deform instantly due to the fluid pressure, but then it will continue to slowly deform or creep over time as the water gradually flows out of the loaded region.
So it slowly compresses further under a steady weight.
Stress relaxation is the opposite. If you quickly compress the cartilage to a certain thickness and hold it there, the initial stress inside the tissue is high. But over time, As the fluid redistributes and the matrix adjusts, the internal stress required to maintain that thickness gradually decreases or relaxes.
So it adapts to being held in a squished position.
Essentially, yes. Both creat and stress relaxation happen because the fluid flow, that's flow-dependent viscoelasticity, and also because the matrix molecules themselves slowly rearrange, flow-independent viscoelasticity. This time-dependent behavior is critical for absorbing shock gradually and protecting the bone underneath from sharp impacts.
Which brings us back to that structural gradient you mentioned earlier, the huge difference in stiffness between cartilage and bone.
It's massive. Cartilage has an elastic modulus and measure of stiffness around 0.5 to 0.9 megapascals. Bone is up around 20 gigapascals. That's like comparing, I don't know, firm jello to concrete.
Thousands of times stiffer.
Exactly. Cartilage has to act as that perfect transition zone, smoothly transferring the load from the soft tissue environment of the joint to the incredibly rigid bone.
Without that gradient?
The stress would concentrate right at the junction, and it would fail very quickly under repetitive loading, especially at places like entheses, where tendons attach. That smooth transition created by the zonal architecture and the calcified layer is absolutely essential for durability.
Okay, a mechanical marvel, but biologically fragile. Let's look at what happens when that marvel starts to break down. Section 3. Clinical breakdown. The main pathologies of cartilage.
And again, the type of cartilage involved often dictates the specific disease or injury pattern we see. By far, the most common issue globally, especially affecting hyaline cartilage, is osteoarthritis, OA.
Often just called wear and tear arthritis.
Yeah, that's the common term, though it's a bit simplistic. It's really a disease of the entire joint. Involves the bone, the synovium, ligaments, but the hallmark is the progressive breakdown and loss of the articular hyaline cartilage.
Which joints are most affected?
Typically the hylo joints, knees, hips, hands, spine. Major risk factors are age, obesity, previous joint injury. Genetics plays a role too.
What's actually happening in the cartilage matrix during OA?
It starts subtly. The matrix starts to lose water, it dehydrates. Those big proteoglycan aggregates break down into smaller pieces so they don't hold water as well.
Losing its cushioning ability.
Exactly. And the collagen network can become stiffer, more cross-linked, making it more brittle and less resilient. The chondrocytes themselves start behaving abnormally.
The maintenance crew goes rogue.
Sort of. They start overproducing enzymes, particularly matrix metalloproteinases, MMPs, that actively degrade the collagen and proteoglycans. At the same time, their ability to synthesize new, healthy matrix components declines.
So it's a double whammy: increased destruction, decreased repair.
Precisely. That balance tips heavily towards breakdown, the cartilage thins, cracks, erodes away, and eventually you can get that painful bone-on-bone contact.
Okay, that's OA in hyaline cartilage. What about fibrocartilage failure? You mentioned the spine.
Right, spinal disc herniation. Here, the failure is usually in the annulus fibrosus, that tough outer ring of the intervertebral disc, which is made of fibrocartilage.
What causes it to fail?
It can be gradual degenerative changes over time, weakening the annulus. Or it can be acute trauma, like lifting something heavy incorrectly, causing a sudden tear.
And the herniation part is the inside stuff leaking out.
Exactly. The soft, gel-like inner core, the nucleus pulposus, bulges or squeezes out through the tear in the annulus and into the spinal canal.
Where it compressed on nerves.
Correct. That pressure on the nerve root causes pain, numbness, tingling, often radiating down a limb. Sciatica is a common example. But it's not just mechanical pressure.
You mentioned inflammation before.
Yes, the nucleus pulposus material itself is highly inflammatory when it gets outside the disc. It triggers a chemical irritation of the nerve root, which significantly adds to the pain. Fortunately, many herniations resolve on their own as the body gradually reabsorbs the extruded material and the inflammation subsides.
Okay, next up, a condition that starts under the cartilage. Osteochondritis dissecans, OCD.
OCD is a bit different because the primary problem isn't the cartilage itself initially. It's a condition affecting the subchondral bone, the bone directly beneath the articular cartilage.
What goes wrong with the bone?
We don't know the exact cause. It's considered idiopathic, but it might involve disruption of the blood supply to a segment of that bone, possibly due to repetitive microtrauma, especially in young athletes. This can cause the bone segment and the cartilage attached to it to loosen, crack, and potentially detach.
Creating a loose body in the joint.
Potentially, yes. The most common location by far is the knee, specifically the medial femoral condyle, the inner part of the thigh bone at the knee joint. That accounts for maybe 60–80% of cases.
And there's a critical difference in how it's treated based on age, right?
Absolutely crucial. We classify it as juvenile OCD if it occurs in kids or adolescents whose bone growth plates are still open.
They're still growing.
Right. And in these cases, there's a much higher chance the lesion can heal on its own with non-surgical treatment, like rest and activity modification. The bone has better healing potential.
But if it happens after the growth plates close...
That's adult OCD. The prognosis is much worse. The lesions are often unstable, spontaneous healing is rare, and surgery is usually required to try and fix the fragment back in place or replace the damaged area. The bone's healing capacity just isn't the same.
Okay, makes sense. Finally, let's talk about what many people, especially athletes, mean when they say cartilage damage. Traumatic rupture or detachment?
Yeah, this is usually where the confusion between hyaline and fibrocartilage comes in. When an athlete says they tore cartilage in their knee, 9 times out of 10, they're talking about the meniscus.
The fibrocartilage shock absorbers.
Exactly. These are commonly torn by sudden twisting injuries, often with the foot planted or direct blows. They can tear in different patterns, bucket handle tears, radial tears.
Can the articular hyaline cartilage also get damaged by trauma?
Oh, definitely. A direct impact, a fall, or even chronic wear and tear in specific spots can cause focal defects, chunks, or flaps in the smooth hyaline surface. But meniscus tears are generally more common in acute sports injuries. And ironically, while trauma is a cause, lack of movement isn't great either.
Because of that nutrient pumping thing.
A prolonged inactivity can actually increase the risk of cartilage degradation because it's not getting that mechanical stimulation needed for nutrient exchange. Use it or lose it, to some extent.
Right, so lots of ways cartilage can fail. Let's move into how we figure out what's wrong and what the first steps are. Section 4, diagnostics and non-surgical treatment.
And diagnosis can be tricky initially because the symptoms, pain, swelling, clicking, locking, can overlap with lots of other joint issues like ligament sprains or tendonitis.
So history and physical exam are key, but imaging is usually needed.
Almost always. MRI is really the workhorse for looking at soft tissues like cartilage and menisci.
Better than X-ray.
Much better. X-rays are great for bones, but they don't show cartilage directly. You might see secondary signs on X-ray, like joint space narrowing and advanced OA, but MRI gives you a direct view of the cartilage, ligaments, meniscus, and any swelling or fluid.
But you mentioned a catch with MRI earlier about accuracy.
Yes, this is a really important clinical point, especially if surgery is being considered. Standard MRI often underestimates the actual size of a cartilage defect.
By how much?
Studies have shown it can underestimate the area by up to 60%. So a surgeon looking at an MRI might think it's a small defect, but when they get in there with a camera, it's actually much larger. This has big implications for choosing the right surgical procedure.
Which is why sometimes more advanced imaging is used.
Exactly, particularly in research or complex cases where you want to know more than just, is there a hole? You want to know about the quality of the remaining cartilage matrix.
Like those techniques you mentioned.
Yeah.
DGA MRI.
Right. Delayed gadolinium-enhanced MRI of cartilage, DGMRA. It uses a contrast agent, gadolinium. Healthy cartilage has a high negative charge because of the GAGs, which repels the negatively charged gadolinium.
So if the gadolinium gets into the cartilage?
It means the JAD concentration is low. The cartilage is losing its vital proteoglycans. Even if it looks intact on a standard MRI, it's an early sign of degeneration.
Measuring the stickiness, basically.
Kind of, yeah, the charge density. Sodium MRI is another research tool that directly measures sodium ions, which are related to proteoglycan content. These give us a biochemical picture of cartilage health.
But for the definitive look, especially before surgery.
Arthroscopy is still often the final step. Putting a small camera directly into the joint allows the surgeon to see the cartilage surface, probe its firmness, precisely measure the size and depth of any defects, and check the meniscus and ligaments too. It's both diagnostic and helps finalize the surgical plan.
Okay, diagnosis made. What are the first lines of non-surgical treatment, especially thinking about, say, a knee injury?
It usually starts conservatively. The classic RICE regimen is step 1.
Rest, ice, compression, elevation.
Rest is crucial. That often means using crutches or a cane for several weeks to completely unload the injured joint. Ice helps control pain and swelling. Compression bandages can help with swelling too, and elevation uses gravity to help drain fluid.
What about medications?
Pain and inflammation management is key. NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, meloxicam are usually the first choice because they tackle both pain and inflammation.
As opposed to something like Tylenol.
Right. Acetaminophen, Tylenol, is good for pain relief only. It doesn't have significant anti-inflammatory effects. So if inflammation is a major component, NSAIDs are generally preferred, assuming the patient can tolerate them.
And physical therapy always seems to be part of the plan.
Absolutely essential. But the goals need to be clear. PT focuses on strengthening the muscles around the joint, like the quads and hamstrings for the knee. Strong muscles act like secondary shock absorbers and help stabilize the joint.
And regaining motion.
Yes, restoring range of motion and flexibility through gentle stretching and low-impact aerobic exercise, like swimming or cycling. But here's that nuance we touched on earlier. While this conditioning is vital for joint health and function,
It doesn't actually heal the cartilage defect itself.
correct, there's no good evidence that simply using the joint more, even with careful exercise, leads to regeneration or thickening of damaged articular cartilage. We're managing symptoms, improving support, and trying to prevent further damage, not regrowing the tissue through exercise alone.
Okay. If rice, meds, and PT aren't enough, injections are often next. Let's talk about the main options. Steroids.
Corticosteroid injections are potent anti-inflammatories. They can provide rapid, though often temporary, relief by calming down a flared-up, inflamed joint. Good for getting acute symptoms under control.
But not a long-term fix.
Generally not, and there are concerns about potential negative effects on cartilage health with repeated injections. Next is hyaluronic acid, HA.
Sometimes called viscosupplementation, like injecting joint oil.
That's the idea. HA is a natural component of synovial fluid and cartilage matrix. Injecting synthetic HA aims to restore lubrication, reduce friction, and it also seems to have some mild anti-inflammatory and pain-relieving effects. Often used for mild to moderate OA, particularly in the knee, maybe more for smaller lesions.
And the third major type, the one using the patient's own blood.
Platelet-rich plasma, PRP. This involves drawing the patient's blood, spinning it down in a centrifuge to concentrate the platelets, and then injecting this platelet-rich plasma back into the joint.
Why platelet?
Platelets are packed with various growth factors. When injected, they release these factors, which can potentially stimulate some local healing response, reduce inflammation, protect the remaining cartilage cells, and perhaps recruit the body's own stem cells to the area.
Who is PRP typically best for?
It's often considered for younger, more active individuals, perhaps with more focal cartilage defects rather than widespread OA, as it's trying to leverage the body's own healing potential. HA might be seen more as providing lubrication and symptom relief in older patients or more advanced OA, but there's still ongoing research defining the ideal patient for each.
All right, so if non-surgical options aren't cutting it, or the damage is too severe, we cross into Section 5, the surgical frontier, restoring the osteochondral unit.
And the overarching goal here, whenever possible, is not just to patch the cartilage, but to restore the entire functional unit, the osteochondral unit, meaning the cartilage and its underlying subchondral bone attachment, trying to recreate that smooth mechanical gradient we talked about.
But first, a situation surgeons often encounter, finding cartilage damage they weren't expecting during surgery for something else, like an ACL tear, these incidental defects.
Yeah, they're surprisingly common. Studies suggest maybe up to 2/3 of knee arthroscopies find some degree of chondral damage that wasn't the main reason for the surgery.
What's the thinking on treating those?
The general consensus, and this is important for patients to understand, is that if the defect is found incidentally and the patient had no symptoms related to that specific spot beforehand, you should usually leave it alone.
Why not clean it up while you're in there?
Because intervening, even just smoothing it down, can potentially disrupt the surface, trigger inflammation, and turn a previously silent asymptomatic lesion into a new source of pain. You risk creating a problem. So observation is often the best course unless it looks unstable.
Okay, so assuming the defect is symptomatic and needs fixing, what are the main surgical tools? Let's start with the simplest, chondroplasty or debridement.
This is basically a cleanup procedure. The surgeon uses shavers or other instruments to smooth down frayed or irregular edges of damaged cartilage and remove any loose flaps.
Does it fix the hole?
No. It's purely palliative, meaning it aims to reduce symptoms like clicking or catching caused by the rough edges, but it does not restore the missing tissue. It's not curative. There's also limited evidence for its long-term effectiveness, and it's generally reserved for superficial damage or situations where more restorative options aren't suitable.
Got it. Moving up in complexity, the technique that tries to stimulate some natural healing. Marrow stimulation, most famously microfracture.
Right. This was a workhorse procedure for many years, especially for smaller defects. The idea is to intentionally injure the underlying bone to trigger a healing response.
How's it done?
The surgeon uses sharp, pointed instruments, like an awl, to create multiple small holes or microfractures through the hard subchondral bone plate at the base of the cartilage defect.
What does making holes in the bone achieve?
It creates channels that allow blood and, crucially, mesenchymal stem cells from the bone marrow to seep out and fill the cartilage defect, forming a blood clot.
So you get stem cells into the area to try and build new cartilage.
That's the hope. These stem cells differentiate and form a repair tissue within the defect.
But here's the catch we mentioned before, right? What kind of tissue does it make?
And this is the major limitation. The repair tissue formed after microfracture is predominantly fibrocartilage, not the smooth, resilient hyaline cartilage that was originally there.
And fibrocartilage isn't as good for this job.
It's tougher and more fibrous, yes, but it lacks the specific composition, water content, and zonal organization of hyaline cartilage. It's mechanically inferior for covering joint surfaces.
So the fix doesn't last.
Often it doesn't. While microfracture can provide good short-term symptom relief, especially for smaller defects, less than 2 centimeters, in younger patients, under 40, the fibrocartilage repair tends to break down over time. Outcomes commonly deteriorate significantly after just 2 to 5 years.
So it might buy some time, but it's not a permanent solution.
They're generally not considered a durable long-term solution for articular surfaces? No. Which leads us to techniques that try to put actual hyaline cartilage back.
Like taking it from one part of the knee and moving it. Osteochondral autograft transfer, OAT, or mosaic plasty.
Exactly. This is a way to directly restore hyaline cartilage for smaller, contained defects, usually less than 2 or 3 square centimeters.
Auto means from the patient themselves.
Yes. The surgeon harvests 1 or more small cylindrical plugs of bone and the overlying healthy hyaline cartilage from a less critical low-weight bearing area of the patient's own knee, usually the edge of the femur near the notch.
Plugs those into the hole.
Precisely. They drill out the damaged area and press-fit these harvested plugs into the defect, creating a mosaic pattern if multiple plugs are used. The big advantage is you're transplanting mature, living hyaline cartilage along with its bony support structure.
Sounds ideal. What are the downsides?
The main one is donor site morbidity. You fixed the defect, but you've created holes where you took the plugs from. While it's usually a low-weight bearing area, it can still sometimes cause pain, swelling, or issues at the harvest site reported in maybe around 3% of cases.
And is it durable long-term?
It's generally better than microfracture, but studies still show some deterioration over time, maybe 5 to 14 years out, particularly if you try to use it for defects larger than that 2-3 centimeter sweet spot. And you're limited by how much donor tissue you can safely harvest.
So for bigger holes, or if the patient's own cartilage isn't suitable,
then you look at using tissue from a donor, an allograft, osteochondral allograft transplantation.
Allo meaning from another person, usually a deceased donor.
Correct. This is the go-to solution for large defects, often bigger than 2 to 4 square centimeters, or for complex situations like uncontained defects, where there isn't a good rim of cartilage around the hole, or as a salvage procedure after other techniques have failed.
How does it work?
Instead of small plugs, you transplant a larger single piece of bone and cartilage, carefully sized match from a tissue bank donor, to perfectly fit the patient's defect. It replaces the entire osteochondral unit in one go.
Advantages.
You can treat very large defects, you restore mature hyaline cartilage and bone, and there's no donor site morbidity for the patient.
Disadvantages.
It's technically demanding surgery. There's a small risk of disease transmission, though screening is rigorous. The tissue viability can be a concern depending on storage time, and there can be issues with immune response or graft integration. However, long-term results can be quite good, with some studies showing survivorship over 50–60% even at 20–25 years.
Okay, so that's transplanting tissue. What about growing new cartilage from cells? Autologous chondrocyte implantation, ACI.
ACI is a cell-based therapy, more of a regenerative medicine approach. It's typically indicated for medium to large, full-thickness defects, again, often greater than 2 to 4 square centimeters, where the underlying bone is generally healthy.
Autologous means using the patient's own cells again.
Yes, but it's usually a 2-stage process. Stage 1. The surgeon performs an arthroscopy to take a small biopsy of healthy cartilage from a non-weight-bearing area of the patient's knee.
Just a tiny piece.
Yeah, very small. Those chondrocytes are then sent to a specialized lab where they are cultured and expanded over several weeks. They multiply significantly, from maybe a few 100,000 cells to tens of millions.
Wow. Then what?
Stage 2. The patient comes back for a second, open surgery. The surgeon prepares the defect bed, and then these cultured chondrocytes are implanted into the defect.
How do they stay put?
They need a cover. Originally, a piece of periosteum, the membrane covering bone, was sewn over the top. More commonly now, a biocompatible membrane, often made of type 3 collagen, is secured over the defect like a patch, and the cells are injected underneath it.
What does the membrane do?
It holds the cells in place, protects them, and acts as a scaffold, guiding them to hopefully produce a hyaline-like repair matrix.
How successful is ACI?
It can produce very good results, especially for larger defects. Long-term studies report favorable outcomes, with survivorship around 70% or more at 10 years, even for quite large defects. It often requires prolonged rehab and sometimes needs to be combined with other procedures, like an osteotomy, to correct alignment if needed.
Sounds complex, needing 2 surgeries. Is there a single-stage cell option?
There are newer techniques aiming for that. One is particulated juvenile articular cartilage, PJC.
Using cartilage from young donors.
Yes, specifically allograft cartilage minced into small particles, obtained from donors typically under 13 years old.
Why juvenile cartilage?
The theory is that chondrocytes from younger donors are more metabolically active, have a greater capacity to multiply, and potentially produce the better quality matrix compared to adult chondrocytes.
How is it used?
The minced juvenile cartilage is usually mixed with fibrin glue and implanted into the defect in a single surgery. So, advantages are no donor site morbidity for the patient, and it's a one-step procedure. Early results seem promising, but we need more long-term data compared to ACI or allografts.
Okay, lots of options for the cartilage itself, but what about really complex situations like someone who had their meniscus removed years ago, the meniscectomized knee?
Ah, yes. This is a major challenge because removing the meniscus, especially a total meniscectomy, has devastating consequences for the joint biomechanics.
Why is losing the meniscus so bad?
Remember, the meniscus, fibrocartilage, acts like a crucial spacer and shock absorber, distributing load across the joint. When you remove it, the contact area between the femur and tibia decreases dramatically.
So the same force is concentrated on a smaller spot.
Exactly. Studies have shown removing the whole meniscus can increase peak contact stresses in that compartment by over 200%. Some say up to 235%.
That sounds like a recipe for disaster for the articular cartilage.
It is. It leads to massively accelerated wear and tear, essentially guaranteeing the development of osteoarthritis in that compartment much sooner than it otherwise would have occurred.
So what can be done for someone in that situation? Maybe young, active, but facing rapid arthritis because of a past meniscectomy.
If the patient is relatively young, say under 50 or 55, has significant pain due to meniscal deficiency, but doesn't yet have severe arthritic changes in the cartilage itself, meniscal allograft transplantation, MAT, is an option.
Transplanting a whole meniscus from a donor.
Yes. A size-matched meniscus allograft is implanted to try and restore that cushioning and load distribution function. The goal is to reduce pain and slow down the arthritis progression.
Does it work?
It can significantly improve pain and function for the right patient. However, MAT is often not done in isolation, especially if there's underlying alignment issues.
Like being bow-legged or knock-kneed.
Exactly. If the patient has, for instance, varus malalignment, bow-legged, which puts extra stress on the medial inner side of the knee where the meniscus was removed, just putting in a new meniscus isn't enough. The alignment problem needs to be fixed too.
How do you fix alignment?
With an osteotomy. For varus knees, typically a high tibial osteotomy, HTO, is done. The surgeon cuts the upper part of the tibia, shin bone, and realigns it, shifting the weight-bearing axis away from the damaged medial compartment and onto the healthier lateral outer compartment.
So it's often a combined approach.
Very often in these complex cases, you might do an HTO to correct alignment, a MAT to replace the meniscus, and maybe even a cartilage restoration procedure like ACI or an osteochondral allograft if there's already significant cartilage damage in that overloaded compartment.
Wow, that's rebuilding the whole knee almost.
It's a major reconstructive strategy, yes. The goal is joint preservation, trying to restore normal biomechanics, protect the remaining cartilage, relieve pain, improve function, and delay or even prevent the need for a total knee replacement, TKA, for as long as possible, especially in younger active patients.
So wrapping this all up, it's clear that dealing with cartilage is, well, it's complicated. We've seen this incredible material, this engineering marvel that's fundamentally handicapped by its own biology. Those 3 A's of vascular, aneral, and lymphatic just make natural repair almost impossible for significant injuries.
Absolutely. And that dictates the whole clinical approach. It requires really precise diagnosis, understanding that even our best imaging like MRI can sometimes underestimate the problem.
Right.
And then careful patient selection for non-surgical things like physical therapy, maybe injections like HA or PRP, knowing their limitations.
And when surgery is needed, It's this whole spectrum of options, isn't it? From just cleaning things up palliatively
Like chondroplasty.
to trying to stimulate some healing with microfracture, but accepting you'll likely get that inferior fibrocartilage.
Yeah, the patch, not the perfect fix.
All the way up to these really sophisticated, high-stakes procedures trying to put back or grow back something that truly mimics native hyaline cartilage.
Like OATs, allografts, ACI, PGAC, all trying to restore that original osteochondral unit.
And it all comes back to that incredibly slow turnover, that 400-year half-life for collagen you mentioned. The body just can't rebuild it effectively on its own time frame.
It can't, which is why orthopedics has poured so much effort into finding ways to intervene, using mechanics, using material science, using cell biology to try and overcome those limitations.
What's the ultimate goal then, biologically speaking?
Ultimately, it's about preserving or restoring the homeostasis of that extracellular matrix. We know OA and degradation involve this chronic imbalance where breakdown outpaces synthesis.
So we need to tip the balance back.
Exactly. And the Holy Grail really remains trying to perfectly replicate or regenerate the unique, organized zonal architecture of native hyaline cartilage. Doing that reliably is still one of the biggest engineering challenges in orthopedics. We haven't quite cracked it yet.
Okay, so here's the final thought looking ahead. This intersection of biology and engineering, it feels like where the breakthroughs have to happen, right?
Seems likely, yes.
We know the mechanical environment is absolutely critical for cartilage health, but its big limiting factor is getting nutrients in and waste out that avascular problem. So how might future technologies, things maybe beyond purely biological approaches, finally crack that code? Could we engineer solutions that achieve true, lasting hyaline regeneration, maybe making joint replacements less inevitable?
That's the billion-dollar question, isn't it? And we are seeing fascinating progress on the bioengineering front that tries to tackle exactly that nutrient delivery issue, almost bypassing the need for blood vessels.
Like new materials?
Potentially, yeah. Think about advanced hydrogels like those freeze-thawed PVA hydrogels people are working on. The goal is to create synthetic materials that don't just mimic the mechanical properties, the stiffness, the shock absorption, but also the lubrication. Some are getting friction coefficients as low as or even lower than natural cartilage.
So a synthetic replacement that works just as well mechanically.
That's the aim. But could we go further? Could we design scaffolds or implants that are not just mechanically sound, but also incorporate ways to facilitate nutrient transport? Maybe microfluidic channels within the scaffold, or embedding time-to-release growth factors or nutrients directly into the material.
So the implant itself helps feed the cells or encourages the right kind of tissue growth independent of blood supply.
That's the kind of thinking. If you can provide the perfect mechanical cues and solve the nutrient transport limitation engineered into the material itself, maybe you can finally overcome the biological hurdles that have held back true regeneration for so long.
It really blurs the line between biology and materials engineering.
It absolutely does. Is the future in manipulating cells? Or is it in creating the perfect environment for cells using advanced materials? Maybe both. The question for you, the listener, particularly if you're in medicine or bioengineering, is how do you see that balance shifting? Can engineering provide the context that finally unlocks the biological potential?
Something to think about. That's it for this deep dive into the complex world of cartilage. We hope this sheds some light, whether you're navigating your own recovery or studying the science behind it.
Thanks for tuning in.